all the way from Greece and Cyprus, a specialist who questions what we accept and rethinks the measures we use. Let us rise and listen to Dr. Vasileios Korakakis.
Mir Majes Tirana, and thank you for having me. My presentation follows the flow, so we started from the brain, we moved to the lower back, and now we're going to move to the knee and discuss about ACL reconstruction. However, I will do an introduction with non-relevant studies just to make my point. Is research essential for clinical practice? All the answers are on the screen. Yes, no, maybe, likely, possibly, but have in mind that evidence-based practice includes a very important part that is the best available evidence. However, the fact that the paper is published doesn't mean that it's a good study. So you have to think critically before you use the evidence into your clinical practice. Life is too short to read the whole paper. This is something that we do in our clinical practice. We read just the abstract. But the abstract is not enough. Among, I think, 2,000 RCTs and over 500 systematic reviews, they found that full consistency of the abstracts with the full text varied between 28 to 73%. That means what is included in the paper is not in the abstract, in most of the cases. And I will just give an example. Sorry for that, it's about dry needling. The effect of dry needling on trigger points and upper quadrant musculoskeletal pain. According to the conclusions of the abstract of this systematic review published in JOSPT a few years ago, maybe more than a decade, it says that there is evidence grade A. We recommend dry needling compared to placebo or sham acupuncture for decreasing pain immediately after treatment and after 4 weeks. And if you want to improve your clinical practice, you can take this message and move it directly to your patients. But if you read the results of this paper, they change a little bit the wording. And they say, yes, dry needling can decrease pain after 4 weeks, but the wide confidence intervals for the overall effect limits the impact of the effect. So yes, it's fine, grade A evidence, but not so much. And if you know how to read the paper, then you will see the forest plot. If the effect estimate confidence intervals crosses the midline, there is no effect. So in the same paper, abstract says, very good, use it. Results say, maybe it's not that effective. And if you're not full, check the diagram. There is no effect between sham acupuncture and actual acupuncture in decreasing pain in the same paper. Have this in mind about the papers that are published. My second point, money talks. So these days, you can publish whatever you want because cash is the best peer review. This paper was published intentionally a few years ago, Temporal Effects of Repeated Spinal Manipulation on Mortality Ratio, a case report. The quite interesting keyword on this study is good at cheese. Plus, the patient that they reported in this case report was a dead person. I'm not joking, this is published. Plus, they say, at the time of the treatment, the patient was no longer worked, of course, he was dead. Vital signs were absent, of course, he was dead. Plus other stuff. Also, he had cognitive behavioral therapy during this process. They had to do 250 manipulations over days, so the intense nature of the intervention, they had to use cousins, next of kin or whatever. And this funny stuff is published, and his grip strength of the dead person improved by some kilotons, and 1 kiloton is like 1 million kilograms. So the one side is that there is a lot of research published that you can use in your clinical practice. However, not all research is equally done or transferable to our clinical practice. And now let's go back to my presentation. I think I made my point. Research is okay, but we need to filter the research through critical thinking and knowledge. You need to have the basic knowledge in order to interpret research and transfer it or integrate it into clinical practice. We're going to discuss about clinical experience and the conflict of experience and evidence. We are going to discuss about where we stand as physiotherapists. We may say whatever we want, but clinical practice does not reflect what we talk in small chit-chats, in conferences or in other places. Back to basics, no reliability, no validity. Reliability is a prerequisite of validity, and if there is no validity, there is no point of discussion. And finally, bad science in, bad science out, bad methodology. Research is not good for our clinical practice. There is always a conflict between, I'm an experienced physiotherapist, I have 30 years of experience, so I know what to do, compared to some other ones that they say, look, let's follow the evidence. What the evidence say, don't use ultrasound in your clinical practice, there is evidence supporting it. And the others say, okay, I have experience, but have in mind that 30 years of experience treating patients doesn't give you and guarantee 30 years of true experience in physiotherapy practice. Because you need to improve yourself by updating your knowledge, you need to use your critical thinking, you need to self-reflect, you need to use metacognition, and finally, you need to apply cognitive reasoning through the process in order to get the experience. From the other side, research cannot directly inform clinical practice, yes, because it's done in a very sterile way. Means that you cannot transfer directly the research evidence into your patient because N equals 1. And research can be done by academics that we have no good idea or clear idea what means treating patients. And this is a very bad thing because practically what I've done in my university is completely irrelevant to a clinician that sees patients through the day, and I have never seen a patient by myself. And finally, research has a lot of methodological flaws that are not quite easy to understand or to comprehend if you don't have the basic knowledge of research. But I think the truth is between these two sides. The answer is 17 years. What is the question? The question is how many years the basic science takes to be translated into clinical practice. And this gap is huge and it's getting bigger, and it varies between the healthcare professions we are discussing. A few years ago, we did a survey across the 5 continents, surveying over 2,000 physiotherapists, MSK and sports physiotherapists, by asking one simple question. Think about the most recent aspect of your clinical practice that you changed. We're not interested about this, but tell us, how did you learn about this? What's the source that actually drives the change in clinical practice? The responses were not that interesting for researchers, academics, and clinicians. Only 5% of the physiotherapists across the world changes their clinical practice based on research, on a published paper. This percentage becomes 7.8% if the physio has a master's degree or a PhD. But actually, how do we change our clinical practice? That's the answer. By attending courses and seminars organized by organizations or private courses. And this makes sense because you will attend a 3-day course, you will get knowledge, and you're going to use it on Monday on your patients. However, this knowledge is not filtered and might be accredited with getting CPD points, but nobody knows who I am. I can write a curriculum ticking all the points that can be assessed by an AI checker to meet the standards to be a CPD accredited course. And taking a little bit further from that, 3 years ago, 319 courses were available for physios and sports scientists in the United States. Of these 319 courses, 66% did not have evidence from clinical practice guidelines, and over 80% of these courses were not backed up by systematic reviews. Not in countries that are not good in terms of physiotherapy. They produce work and consider as good clinicians. And these courses claim stuff, quite interesting stuff, I will not say a lot about this, that the treatment of the rotator cuff disorder is about pelvic imbalances, or that shoulder disorders are related with a delayed vastus medialis oblique activation, and excuse me for my profanity, 3D scoliosis treatment by doing meniscal mobilizations. Apologies, but it doesn't make sense to me. Come on. Yep. Where do we stand as physiotherapists? Back to ACL reconstruction and rehabilitation. A couple of years ago, we published from hospital the clinical practice guidelines in terms of treating patients after an ACL reconstruction, and a consensus statement about the passive modalities states that the evidence for modalities is conflicting and the adverse events, as well as the cost and time required, probably overweights any benefits. I'm going to discuss a little bit about passive modalities in general and what's the reason that we use them in clinical practice, despite the fact that probably are not needed at all. Across the world, survey of ACL rehabilitation practices and current opinions and treatment choices, they show quite interesting stuff. I will start with Greece because this is my country and I want to confront Greek physiotherapists. About 50% of the Greek physios, they use passive modalities by trying to treat ACL reconstructed patients. Some of them, they use acupuncture and other interesting stuff. This is the reality. Plus, in order to give a pass to myself to score, 12% they use their hands in order to evaluate the strength of the quads and the hamstrings. Handheld dynamometry is used by less than 10% of these physiotherapists, and they spend a huge amount of money to buy passive modalities like, I don't want to name anything, that cost hundreds of dollars compared to $1,500 for a handheld dynamometer. Plus, they extrapolate strength data for knee strength by using functional testing as the classic one, that is the single leg hop for distance. Despite that, 75% of the physios, they believe that you should test the strength of the knee flexors and extensors if you want to discharge your patient to return back to sports or physical activity. And this is not only the case in Greece. Across all the published studies, this is the reality to the whole world. A huge percentage of physiotherapists, they use still in 2023, 24, 25 their hands to measure the strength of the quadriceps, and it doesn't make sense. Plus, a bigger percentage is extrapolating strength data within the bigger construct of strength by using single leg hop for distance. No reliability, no validity. Why not to use manual muscle testing? We all know the Oxford scale from 0 to 5. Yes, it's applicable on a neurological patient. However, in a patient with an MSK condition, how far is the 4 or 4 plus to 5? How many steps? How many kilograms? We have no idea. So for me, this is irrelevant, and this knowledge is way back explained in detail by using handheld dynamometry and using my experience and my hands. And it says that the accuracy was never greater than 78% from between side differences by using the hands, and never greater than 74% for strength deficits. So it means you cannot measure strength by using your hands. And this example was done in the shoulder, where the external rotators might be like something 17 to 20 kilos max, and the internal rotation a little bit more, like 27 to 30 kilos. So what about the knee? Quote to take back home: if you're interested in something, you should measure it using a device that gives you units of this something that you care about. So I cannot measure my weight by eyeballing. Strength should be measured with a device. And I told you, don't use manual muscle testing. Shall I use a handheld dynamometry? Do you agree that we should use a handheld dynamometry? Yes or no? Yes. Good. So this kind of measurement here, the product was at the mean value of strength of knee extensors in this angle was 25 kilograms. And I wonder how this paper managed to publish and get past clinical review. Because we know from a study in hospital, for example, that the mean strength of quadriceps in this degree by using handheld dynamometry is 50 kilograms force, not 25. Point to take home: the device will always be better than you if you know how to use it. So it doesn't matter that I have an equipment with me. If I don't know how to use it, it's not going to be reliable. We use different metrics and indices in order to progress and as criterion to return to sports after an ACL reconstruction. And according to a recent systematic review, not very recent, 5 years ago, but it made a big debate in the literature when it was published, what is used in order to progress and return to sports? Mostly it's strength values, quadriceps and hamstrings, plus functional testing, single leg hop for distance or triple hop for distance, the classic ones. Some of them, they use other functional testing also. But let's talk about reliability. From a systematic review, the most important and clinically friendly tests measure the distance that you hopped, or triple hop, or 6 meters timed hop. These tests, they have no reliability, so I'm not discussing about validity. We have no idea if these tests are reliable. So if no reliability, no discussion of validity, no point. What do you see here? This is the same person, operated, it's one leg. What do we measure? In this test, it's a single leg hop for distance, and we measure the distance hopped. Yes, that's it. 1 meter with one leg, 95 meters with 95 centimeters with the other leg, so the symmetry is 95%. Tick the point, pass criterion. Do we measure knee strength by using this test? No, we don't. Do we measure the construct of knee strength by doing this test? Not exactly strength, but something similar that is a product of the knee. Unfortunately not. Because with this test, we measure the ability of the knee to decelerate the force, to absorb the force. And unfortunately for us, we cannot see the force. We can see differences in the strategy. We can see differences in the upper body. We can see differences in the knee angles. We can measure the distance, but the product of this functional movement assesses the ability of the willingness of the individual to absorb the landing force during landing. This is what we did in hospital. We measured everything by using devices that gives you the unit of what you're interested in, like force text, and we figured out that single leg hop for distance in ACL reconstructed patients that meet the criterion of limb symmetry index over 90%, they didn't meet the actual criteria because there is some hidden deficits that you cannot see with your eyes or measured with the distance. Lower knee absorption and differences in kinematics. I'm not going to stay on this. And we moved from clinical observations into research that could probably inform clinical practice. We figured out that by measuring stuff like distance, never decreased the range of re-injury. So probably we were not measuring what we're supposed to measure. So we evaluated the single leg hop for distance and the vertical hop or the vertical jump and see the contribution of the knee, hip, and the ankle joint. We have two phases, the phases of takeoff and the landing. With regards to the single leg hop for distance, the percentage of contribution of the knee to the distance hop, it's only 13%. So don't use a single leg hop for distance if you're interested in measuring the distance for the knee joint. But it's a perfect test to assess the hip and the ankle. So it's irrelevant for one joint, but quite relevant for other joints. So it's valid for the hip, but it's non-valid for the knee. If you have a force plate, the knee absorbs 65% of the energy produced during this functional test. So it's a very nice test if you have a force deck for the knee. If you don't have a force deck and you have a measure, a tape, then use it for the hip and the ankle. With regards to the vertical jump, the condition is completely different. The energy to take off and absorb the landing, it's equally distributed between the three joints, hip, ankle, knee, and ankle. And knee. I figured it out? Yes. Okay. So if you want to measure something with patients that are ACL reconstructed, measure the distance, not the height they hop. Watch the video and then we vote. Which knee is the injured knee, the ACL reconstructed knee? And it's quite clear and obvious. So if you put parallel videos, you can actually see what's going on. Once more, same person, we remove the hands, just to not make it difficult for you. Landing. Who says that the ACL reconstructed knee is the top one? Nobody? A few. Who says that the ACL reconstructed knee is the lower one, the bottom one? Good. Unfortunately, it's the opposite. Why? Because the bottom knee absorbs the energy very nicely despite the lack of balance. And if you check the top knee, it's a stiff knee landing. That means take the load away from me. But this is just an assumption, so you need to measure it. You cannot eyeball anything. You cannot use your eyes to measure the force. We cannot see the force. So we did a study evaluating patients after an ACL reconstruction that meet all the required criteria of limb symmetry indices, above 95%, and measure them by using forced legs. And this is the drop jump, that is from a height, you drop, single leg, and jump again, and you measure the height that you hoped. And we figured out, yes, that the height was similar. We meet the criteria of limb symmetry index. However, all the ACL reconstructed patients in hospital, they shifted the load from the knee joint to the hip joint. So there is a big difference to the output compared to the parts, the interplay of the parts of the joints of the lower limb that gives you this output. And you need to consider this in your clinical practice. So there is a research and practice, and there is a big gap, and how we're going to bridge this gap. And the answer is one: be data-driven. Measure, assess, evaluate, transfer it to your patient, transfer this knowledge into something that is clinically applicable. And I will give you just an example and finish my talk. Return to running after an ACL reconstruction. A systematic review assessed all the studies. Most of the studies, they said, okay, you can return to running at 8, 12, a little bit more, but most of the studies, they said around 12 weeks, with a few studies reporting a smaller time period from the operation. And we say, okay, so time is one, but it's not the absolute criteria in order to return to running. You should have more criteria. In the clinical practice guidelines from hospital, again, we stated that timing should be more than 12 weeks, and I will stick only with one criterion, strength again. 70% limb symmetry index between the injured and the non-injured leg in terms of strength. What can we take home from this presentation? A critical eye is always essential. Use your critical thinking, because research quality and methodology and in general is a continuum, and it's not a binary. It's not good or bad. It's not white or black. There's many shades of gray between them. Physio tools and measurements are not reliable or unreliable. Most of the measurements that we use and the tools that we have in our clinics are more or less reliable or more or less valid. Use your clinical reasoning in an evidence-based and data-driven clinical environment and try to translate this information into clear and actionable clinical plans. And finally, read the research and try to be empathetic with your patient. It's not about only research, it's not about the needs, it's about the person. Thank you for your time, and I'm ready for your questions. We have questions?
Yeah.
Okay, I'm ready.
Thank you for this very good presentation. I really enjoyed it because I'm working with kinetics since 2012. I did some research and I'm always interested. And this was a very good presentation, which I liked very much. So I'm coming from alma mater Resonance University from Pristina College, and my name is Dr. Ismail. So my question is about this last sentences. I was wondering, for this evaluation, just you said or you mentioned or you just did it 60 degrees per second.
Yes.
So this follow-up, I just wanted to know why you did not use it 120 to 140 degrees, and also did you account this value as the absolute or relative values, or only as a process of the work? Thank you.
We used to do two different measurements in terms of strength because you can reveal deficits within the joint by using faster speeds or slower speeds depending on your objective. We were aiming for max strength and the average strength that is according to body weight, so it's standardized, it's not actual values to what you see there. We have measurements with 225 degrees also. So we have all the data. This is one example of that. The same discrepancies can be found even in higher speeds.
You just follow up the protocols to the
Yeah.
Thank you very much. It's really, really very good.
Thank you very much for your question. Thanks.
Hello, thank you for your amazing presentation. And what you are doing with ACLR is very helpful for us in this explanation. I would like to ask about the limb symmetry index that you mentioned at the end. Do we take into consideration the contralateral leg that may go some tract because of the ACL procedure, reconstruction may go through untrained procedure, or might be atrophied a little?
Thank you for it's a very nice question. So we recently published another study that is called Beware of the Moving Target. And this has to do with the uninvolved side. So it means if you start strengthening the involved side along with the uninvolved side, you're just following something that is moving. So you cannot compare this. You always, though, have different ways of evaluating and establishing if your control leg meets the criteria of strength, for example, by using normative values or sport-specific values that are published from, as I remember, Van Melik. There's a big study with sports-related reference values for the involved and uninvolved leg. So I don't know if I answered your question. Yeah. And this is not our work only in Aspetar. It's a big team that is working there with the lead of Rula Kotsifaki, that is a queen of biomechanics and assessment, and guided by Rod Whiteley. These are amazing people, both of them. They are a very good friend of mine, and Rod is my mentor. It's something that is done not because of Aspetar and money. Equipment is the money, but actually the interest of all these people is not producing research, because nobody's getting money from research unless there is a fund behind that. We do this in order to improve our clinical practice. And you cannot improve your clinical practice if you're not data-driven, if you don't know what's going on. You cannot base your reasoning on assumptions. You have to have solid evidence, and solid evidence are numbers. And patients like the numbers. If I will measure your knee strength and I tell you your left side is non-painful, non-operated, you have strength 55 kilograms force, and the other side is 25, what are you going to tell me? I'm going to make it look the same. I'm going to produce the same. So this is something that is measurable. And every time you will see the patient, they will say every week, this is my personal experience, and the three most dangerous words in our science is in my opinion, but I will tell you my opinion. The patient, every time that comes after an assessment, will tell you after next week, can we measure again? I want to see where I'm. So there is a motivation also. Try to use numbers in your clinical practice. This is my opinion.
Thank you.
You're welcome.
Thank you for this presentation, really interesting. My name is Ibrahim. I would like to ask about your opinion about neurocognitive treatment of ACL, and during this study that measuring knee strength, does this study take into consideration the external focus during instruction for testing, and the measurement, its difference between an external focus of instruction and internal focus?
This part, it's a really nice question, the neurocognitive part of ACL rehabilitation, and it slowly gets into clinical practice. We use external focus during the process of rehab, but during the measurement of strength, there is no external focus. It's push as far, as hard as you can, and there is also verbal and tactile feedback and screaming, and I'm not aware if you have ever seen a measurement of knee strength. There are 3 people shouting at this guy that is pushing and pulling, push, pull, push, pull, push, pull. So there is motivation. There is no external or internal focus during the measurement, but external focus is part of the rehabilitation process.
Thank you.
You're welcome.